So thank you for inviting me today. My presentation is about jaundice in the first few weeks of life in the outpatient setting. I do not have any disclosure in relation to this presentation. Is that clear? Shall I start?
Yes, continue. Yes,
you
are well.
So jaundice is a very common problem in the first few weeks of life, and more than half of the babies become jaundice. This is why it is very important to know what to do with them in the outpatient settings in the first few weeks of life. So my presentation is actually two parts. The first part will talk mainly about jaundice in the first 2 weeks of life. And then the second part will talk about prolonged jaundice, which is jaundice after 2 weeks of life in term babies. 1 second. Sorry. So talking first about bilirubin. So bilirubin results from the breakdown of heme, and the heme oxidase changes hemoglobin to biliverdin. Sorry, I think there is too many people on the screen. Do you mind if you can close your cameras so the presentation is more clear?
Yes, Dr. Sanaa, I would suggest this. You may click on the video icon on your end. On the lower left, you can turn it off.
Okay.
Yes. So we can hear your voice well.
1 second.
Dr. Sanaa, it's turned off now.
Okay, good. So heme oxidase, it changes hemoglobin to biliverdin. Biliverdin, which is green, is reduced to bilirubin, which is in theory yellow in color. Unconjugated bilirubin is highly insoluble. And then bilirubin will get conjugated in the liver by the enzyme UGT. There are two types of bilirubin. So we have the unconjugated part, which binds to bilirubin. It is fat soluble. It can cross the blood-brain barrier, and it is toxic in high level in the brain. This is why we concentrate in jaundice in the first 14 days of life in the unconjugated part of bilirubin. The conjugated type is usually conjugated with a glucuronic acid in the liver. It is water soluble. It is excreted in the urine and the stool, and it is not toxic. And the conjugated bilirubin becomes really important for us when we talk about prolonged jaundice, which is after 14 days. So as I said before, jaundice is one of the most common conditions requiring medical attention in newborn babies, and approximately 60% of term babies and 80% of premature develop jaundice in the first week of life. 10% of breastfed babies are still jaundice at 1 month of age, and this is a significant ratio. In most babies with jaundice, there is no underlying disease, and this early jaundice, we call it usually physiological jaundice, is generally harmless. Pathological causes are there, but they're very important to rule out, and it can coexist with physiological jaundice. We should not rely on visual inspection alone to estimate the bilirubin level in a baby with jaundice. So we should not have the habit of looking at the baby and say, oh, this is very mild, we don't really need a level. And we should have the habit of measuring the bilirubin level for any baby who's jaundiced. I will talk later about the visual inspection because I have more information about it. So we should not measure bilirubin level routinely in babies who are not visibly jaundiced. So if we have a baby in the first few weeks of life in the clinic, and the parents say, was jaundice and it resolved completely, we should not just check the bilirubin level routinely. So the NICE guidelines identified 4 categories of babies that are a high risk to develop significant hyperbili. And what I mean by significant hyperbilirubinemia is bilirubinemia that will need treatment. So the first one is the gestational age under 38 weeks, a previous sibling with neonatal jaundice requiring phototherapy, mother's intention to breastfeed exclusively, and visible jaundice in the first 24 hours of life. So when we actually see these babies or discharge them after birth, we should think about what sort of support we have in our community. So for example, in Europe, they do have health visitors that will be and midwives that will be visiting their family regularly after birth. So it is their job to detect jaundice and to refer the baby back to the hospital at any stage. Unfortunately, in the Middle East, in some countries, we don't have a clear system. So most people will just seek advice, usually at 2 months, to take their vaccination. So if they were not educated about jaundice and when to seek advice, they may notice the jaundice, they may ask, somebody about it. Maybe someone will tell them who's not medical, it's okay, all babies will become jaundice, so they won't seek medical advice. And if the jaundice is high and require treatment, the baby may be at risk of complications. So we should identify these risk groups and have a clear plan to follow them up, and also educate the patients clearly before discharge to be sure that we don't miss these babies. There are other risk factors for jaundice that are not from the NICE guidelines, but from other guidelines, which is low birth weight, mother with a blood group O or rhesus negative, G6PD deficiency, sepsis, babies with Kifel hematoma or bruises, and babies of diabetic mother. I mentioned before about the visual assessment of neonatal jaundice, and this is what we call a Kramer's rule. So we can use it, but we should not depend on it solely in treating the patient or in deciding on sending the patient for a blood test or not. But it is helpful, and the rule in it is the lower is the jaundice, the higher risk that the level is significant and it will require treatment. So they divide the baby into 5 parts. And as we see in this picture, the lower is the jaundice, the higher level, as you can see, if you look at the range of the serum bilirubin. So in jaundice, according to the NICE guidelines, we should not depend a lot on the direct Coombs test. So it is important, we should do it in some cases. And sometimes if there is a problem with the blood group, we may do it from the umbilical cord. But if it is negative, that does not mean the baby is not at risk to develop jaundice that may require a treatment. In the past, maybe 20 years ago, people used to depend on the albumin bilirubin ratio, but that is not the case, I think, for a long time. And according to the NICE guidelines, they do not encourage people to subtract the conjugated from the total bilirubin to have the unconjugated and make the decision for jaundice. And again, I don't think anybody is doing this at the present time, but that was the practice maybe 15 to 20 years ago. So the most common cause of jaundice in the first 2 weeks of life is usually the physiological jaundice. In order to call it physiological jaundice, it should not be in the first day of life. So it should be appearing after 24 hours of age. The bilirubin should not rise quickly, and it should not rise more than 5 milligrams per deciliter per day. And there are 2 units usually to measure. There is the micromole per liter, and there is the milligram per deciliter. And you can multiply the milligram per deciliter by 17 to have the other one. I'm more used to the micromole per liter, and usually the 5 milligram per deciliter equals about 85 micromole per liter. Physiological jaundice usually peaks between day 4 to 6 in term babies and slightly later in premature babies. It should be serum bilirubin level less than 15 milligram per deciliter, and that is around 250 micromole per liter. So you shouldn't have a very high bilirubin level in order to be able to call the jaundice physiological jaundice, and it should actually resolve by day 14. So it's not a prolonged jaundice. What is the investigation that we usually should do for babies who have jaundice in our clinic in the first 14 days of life? So a serum bilirubin, a total serum bilirubin, a packed cell or hematocrit to be sure there is no polycythemia. We need the mother's and the baby blood group and DCT positive. And if we are in the area where G6PD is high, like Middle East or Mediterranean area, or there is a family history of G6PD, we should be doing the test. The rest of the tests, we sometimes also do renal profile to rule out dehydration, as this may make the jaundice worse. And the other test will depend on the clinical case. If we think about sepsis, we will do a full septic screen. If we think about urine infection, we will do a urine culture. It is recommended, to be honest, to do a urine culture if you're investigating a child of jaundice, but I'm not going to go into the discussion of the urine culture because we're all aware if it is not corrected in the right way, it may be a false positive result. You will be treating and investigating the child. And I think the most common problem is using the bag sample in collecting the urine. So the contamination is usually very high. We need to remember in this age group, the bag sample should not be used. I'm talking about outpatient setting, but I do encourage everyone in the outpatient setting to have like a small chart to give some reference about treatment levels, as sometimes if we're not doing a lot of inpatient admissions, you may forget the guidelines. So it is nice to have some sort of reference to know when you will need to admit the patient for phototherapy. So if you, by chance, which is not really common, you've seen a baby in your outpatient setting for a reason, parents came quickly to you because of jaundice. If it is in the first day, which again, I will say it is not very common because most babies will be still inpatient at that time. What I will recommend is that you should refer them back to the hospital as they need an urgent serum bilirubin and they need also observation and a 6-hourly bilirubin level, even if it is below the treatment line. So the best choice for these patients is to go back and be admitted to the hospital. So why we worried about jaundice, and I'm sure you all know this, it is mainly because of the complication of the high, as I mentioned, unconjugated jaundice in the first 2 weeks of life. And the complication that we all worry about is the kernicterus. It is a very rare complication of high unconjugated jaundice. It is not really common, but it is a disaster. It is very significant. And we treat and do everything for jaundice to try to avoid this small risk. It can be, it's usually a toxicity to the basal ganglia and their various brainstem nuclei. But babies at increased risk of developing kernicterus are the following group. Babies with a serum bilirubin level greater than 340 micromole per liter in babies with a gestational age of 37 or more. A rapidly rising bilirubin greater than 8.5 micromole per liter per hour. clinical features of acute bilirubin encephalopathy. So when I talked about the encephalopathy or brain toxicity, the symptoms are usually poor feeding, irritability, high-pitched cry, sleepiness, apnea, hypotonia, seizures, and arching back are usually late signs. So when you assess any patient with jaundice, you should be looking at this, especially if the level is high and near exchange transfusion level. So what are the long complications of the brain toxicity? Babies can have cerebral palsy, hearing loss, learning disabilities, involuntary twitching of different parts of the body, abnormal eye movement, gaze usually upwards, poor development of the teeth. So the second part of the presentation, I will be talking mainly about prolonged jaundice. And I'm sure you all know this, but just to revise the definition, it is jaundice lasting more than 14 days in term babies and 21 days in premature babies. So it is very common to see this in our outpatient setting, and even if it is very mild and decreasing, we still should do the investigation and the blood test. It is common, so it can occur in 2 to 15% of all neonates and 15 to 40% of the breastfed babies. So the most important step when you see a baby with a prolonged jaundice is to know if it is conjugated or unconjugated by doing the investigation. So there are different guidelines and protocols of how to investigate a prolonged jaundice. But the first step for general pediatrics, the recommendation are mainly CBC, blood group, direct Coombs test, hepatic profile, including direct bilirubin, a thyroid function test, and the urine culture here is important, and possible G6PD. We should take a very good detailed history, and we should be asking mom when the jaundice started. Is she bottle or a breast feeding? We should look for her blood group and what's the baby blood group. We should look at medication history, including vitamin K at birth. We should ask about the baby activity, feeding and sleeping. And we should not forget to ask about the stool color, which is very important. And I will talk about this more in detail later, the clay-colored stool. We should also investigate the family history if they have any hematological diseases, liver diseases, metabolic diseases, and explain death. In examination, it is head-to-toe examination. We should look for any dysmorphic features. We should examine the baby, look at the behavior activity. Abdominal examination is vital, and we look for hepatomegaly or splenomegaly. The neurological examination is very important, and rash. So the prolonged jaundice is divided into two parts. Is it conjugated, as I said before, or unconjugated? We worry more about conjugated jaundice, and I will talk about this later, and I'm now talking about prolonged unconjugated jaundice. So the causes are usually divided into three main groups: bilirubin overproduction, impaired hepatic uptake, impaired hepatic conjugation. So what are the causes of unconjugated hyperbili? And this is from up to date. So it is hemolysis, and the hemolysis can be extravascular or intravascular hemolysis. So extravascular, it can be the Keffel hematoma, hypersplenism, and intravascular hemolysis. The most important one is the G6PD, the hereditary spherocytosis. And there can be also infection, autoimmune hemolytic anemia, microangiopathic hemolytic anemia, and drug-induced anemia. So the second category is the impaired hepatic uptake. And the main causes are the heart failure, portosystemic shunt, some patients with Gilbert disease, and certain drugs like rifampicin. The last category is the impaired bilirubin conjugation, and it has the inherited and the acquired part. The inherited part is the Klickler-Najar syndrome, Gilbert syndrome. The acquired is the most common cause is the breast milk jaundice. And hyperthyroidism, drugs, Wilson disease, but this is usually later in life. So the most common causes of unconjugated prolonged jaundice is hemolysis and breast milk jaundice. Breast milk jaundice, we need to remember that this is a diagnosis of exclusion, and we usually try our best to investigate and to monitor our baby to ensure it is the case. And it is not enough because mom is breastfeeding just to blame it on the breastfeeding, and we should still do bloods and investigation and monitoring. So why breast fed babies are more prone to have prolonged jaundice? And this is mainly because the breast milk contain factors that may inhibit the conjugation of enzymes in the hepatocytes. And it also have the enzymes glucuronidase that breaks down conjugated bilirubin to form unconjugated bilirubin, and hence increase the enterohepatic circulation of bilirubin. So we'll talk now about prolonged conjugated jaundice. So prolonged conjugated jaundice is always pathological, never physiological, and it can indicate hepatobiliary dysfunction. It affects 1 in 2,500 term infants. Its most common cause in the first 3 months of life is biliary atresia. 25 to 40% of prolonged conjugated jaundice is caused by biliary atresia. So what are the targeted investigation when you see a patient with a prolonged conjugated jaundice? It is CBC differential, clotting. You need to look at liver enzymes. GGT is very important. So if you have a conjugated jaundice, you should always send a GGT. In some hospitals, GGT is part of the hepatic function, and in other hospitals, it is separated. So if it is separated, please do not forget to ask for it, as it helps with the diagnosis. Total bilirubin and a direct bilirubin. And to assess the liver function, we also have the albumin and glucose. We can check alpha-1 antitrypsin and a thyroid function test. We can send the urine for analysis and culture and reducing substances to rule out galactosemia. And it depends. If we feel the patient is well, we may not need to send any cultures, but if the patient is sick, we need to rule out sepsis by doing a full septic screen. But this is a clinical decision, and every patient will be different. So number 3 is not a must, as most babies we see with prolonged jaundice are well babies. And we should obtain an ultrasound of the liver. So this is one of the most important slides, and this is, to be honest, the main message of all this presentation. I think there are many different guidelines, and for general pediatrics, it can be confusing. Sometimes it's at what level do we need to send the patient to pediatric hepatology? And there are different numbers in different guidelines, as I mentioned, but as we can see here, the NICE guidelines, any conjugated level more than 15% of the total bilirubin, or if it is more than 25 microgram per liter. So in England, that was mainly our magic number, the 25 micromole per liter. So at any stage we are near this, or as I said, it is not and, it's or, either this or both should be fine, but one is enough, or the 15%. I'm aware that other guidelines will have, instead of the 15, it will be 20%. any conjugated level above or equal to 17 micromole per liter is considered pathological. And this is according to the NASPGHAN, which is the North American Society for Pediatric Gastro, and for ESPGHAN, which is the European Society for Pediatric Gastro. So to summarize this, I think to be on the safer side as a general pediatrician, I will take the 15% or the 17 microgram per liter. So if you have your conjugated bilirubin 17 microgram per liter, it should be, you should send it you should refer the patient to pediatric hepatology. So the stool chart is very important, and sometimes we do tell parents to watch for pale stool, white stool, clay-colored stool, but we should be clear that they do understand that it can be slightly difficult sometimes to be 100% sure. And we should give them the advice, even if it is in any prolonged jaundice, even if it is not a conjugated, we should always tell them, if you notice the stool change to become clay-colored, that you should actually seek medical advice urgently. And it is a good idea to give them the card, which is the stool color card. You can use the one from your hospital, or you can use any from the internet, but the parents should have some sort of a reference, because as I said, it is slightly difficult, and many parents, you do ask them, what's the color of the stool? They say, okay, but when you actually look at the stool yourself, you notice that it is not normal. I think the other trick also, that sometimes the stool may be slightly white in color, but because it is contaminated with urine, the urine may cover the out surface of the stool, give it the yellow discoloration. And what happens sometimes, and when we see the patient in the clinic and we see the stool, sometimes if you actually try and break the stool, if you're not 100% sure, you can notice sometimes that when you look at it from the inside, the stool, it can be white, and it is just yellow from the outside as the pigmentation is from the urine. As we have app for everything now these days, there is also an app for this. It is called Poop MD. This app is designed by Johns Hopkins Hospital. So it is an application with an access to the camera where parents can take a photo, and it will link them to stool chart. So they just have the application downloaded on their mobile. If they have, the suspected nappy, they're not sure what to do with it, they will access it with the camera, and the photo will link them to the stool chart and will give them the color and recommendation. So it says suspicious color, please seek medical advice, or normal color. So it has the color analyzer. So I mentioned before that the most important cause for conjugated jaundice in the first 3 months of life is biliary atresia. So what are the other causes? The other causes are less common, but they're also important, although the biliary atresia is very important because the diagnosis should be done quickly, and I will mention later why it should be done quickly. So we'll go through this quickly. So we have the multisystemic genetic diseases, Alagille syndrome, cystic fibrosis, mitochondrial disorder, hypopituitarism, and then we have the extrahepatic colorectal cyst. If we have a stone, neonatal sclerosing cholangitis, hepatocellular disease, alpha-1 antitrypsin, bile acid synthesis defect, and bile acid conjugation defect, and important error of metabolism like tyrosinemia and galactosemia. So this is the last part of the presentation, the biliary atresia. And as you can notice, the prevalence is different in each country, but we should always remember this diagnosis when the stool has no color to it. if the GGT is high or there is abnormal or absence of gallbladder on the fasting ultrasound. We need to remember that the gold standard for the diagnosis of biliary atresia is intraoperative cholangiogram. So this is just for your reference, as I think we're running slightly off time. We started a few minutes later, but it's okay. So there are classification and there are a few types of biliary atresia, but I think the main message from the slide that it should be diagnosed early and the patient should have the operation before day 60, because this will relate to a better prognosis. And these are my references. Thank you.
Thank you, Dr. Sanaa, for this excellent presentation that is full of very important information and knowledge. You do have only 2 questions I would like to ask you to answer on the chat.